Well, good evening, everybody, and welcome. Super excited to be able to join you all this evening and to share a little bit about my passion for this topic. So this topic we're going to talk about this evening is, of course, that of biologics, and a topic that I am familiar with because every day in clinic, I am participating in biologic procedures to help people achieve their best and highest level of function. So this evening's ground rules, we're going to be going over this topic. We're going to be talking about the facts, the fiction, the clinical application. I ask that you put your questions into the YouTube feature. So put them in there, or if you come up with any, feel free to email them to us at essersports@gmail.com. But ideally, so we can answer them today, put them in the YouTube, and then I can reply back at the end of this video. All right, we're going to get into some serious science, so I hope you've got your scientific hats on. To get started, a little bit about me. For those of you who are not familiar with me, I am a sports medicine and lifestyle medicine physician, double board certified in PM&R and sports medicine. I did my medical school at the University of South Florida. I did my residency in PM&R at Harvard Medical School, sports fellowships at Mayo Clinic. Then I was with a large corporate orthopedic group for about 10 years, where I started the biologics program. And then 2 years ago, went out on my own to run biologics the way that I believe they should be done, which is in a very fair and affordable way, and with the best, highest quality sort of care. So the best yields, the best counts, all ultrasound guided injections, et cetera. When I was with a large corporate entity, I was the team physician at UNF, the Division I university here in Jacksonville, for 7 years, caring for those athletes and doing a bunch of biologics on them. And also was a teaching faculty member for Mayo Clinic, St. Vincent's residencies and fellowships, as well as Brooks Rehab. So I love teaching, and I'm excited to be here with you this evening to share some of this topic. Now, standard approaches to musculoskeletal medicine normally revolve around these issues, right? Oral medicines, injectables, surgery, therapeutic stuff, supplements, maybe modalities like acupuncture, laser, chiropractic, body work of different kinds, et cetera. And while these are great, they fail to capture the full sort of black bag of everything that we have to offer people with musculoskeletal issues. If you go back and watch our video from last week, we talked about the influence of nutrition on your musculoskeletal health. It's a good one with a lot of applicable things to every single one of us. Tonight, we're going to talk about biologics, what that means, what that definition of that word even is, et cetera. So let's get right in. We're going to define terms related to orthobiologics. We're going to engage the science. We're going to review some patient selection. And I hope that I'll equip you, right, to kind of think about the application of these to your life or to friends or family's lives. And in addition, I know we've got a bunch of healthcare practitioners watching this evening. So hopefully I can give you some resources that can assist you in making healthy decisions and science-based decisions for your patients. So let's start simple with a case. Let's say we've got a 58-year-old male who comes with bilateral knee pain, and he has x-rays consistent with some moderate osteoarthritis. His body mass index is elevated at 35. Remember, we like to be around 24, right? So he's obese, and he's got a bunch of medicines related to that obesity, including his hydrochlorothiazide and lisinopril for the blood pressure, metformin for his type 2 diabetes, and his omeprazole for reflux. And of course, with all these problems, he's depressed, so he's on Prozac as well. And this is a very common sort of a chart, right, in America today, all these medications and all these problems. Now, the standard of care might be, hey, here's some meloxicam, here's an injection, weight loss is important for you, and we'll see you in a couple months, right? And see how you're doing, and we'll repeat your injection. Well, I would argue that that's not superlative care. I would argue that there's more that could be done here from a complete comprehensive approach to this patient. Here's another example, 62-year-old female loan originator, right, with back and buttocks pain for 6 months, right? Worsened prolonged standing and walking, improved with sitting. And, waist hip circumference is 1. She's on some cholesterol medications, some hypothyroid meds, some blood pressure meds. The standard of care would be give her some, medications to help with her numbness and tingling in her legs, maybe a Medrol dose pack. Maybe say, hey, losing weight will help your back. And send her for a course of PT and then follow up. The reality is, though, I think there's more, again, that we can do. And we're going to talk about some of the things tonight. And then you're going to go back and watch the video that I put up last week about musculoskeletal healthcare and nutrition. Your body's pretty amazing, really. I mean, it is. Every time I think about our bodies, I'm just astounded by their self-regulating and self-healing abilities. And while they're not perfect, what goes on in them day in and day out to keep you and I healthy is absolutely remarkable. Without us having to think about it, having to talk about it, anything, right? It just kind of happens, which is amazing. Now, what occurs, right? What occurs there? We know that, let's say you get an injury, right? When you have that injury, then what occurs to our body is the body begins to heal, right? And how does it heal, right? How does it heal? Well, it heals by these internal self-regulating mechanisms. And these mechanisms, as soon as you have an injury, those mechanisms are turned on. In the biologic world, the things that are turned on, of course, are the different growth factors that are released into the bloodstream. And these growth factors, in particular the platelets, right, they collect in an area of injury and they attract other healing factors, our white blood cells, our stem cells, et cetera. But they release growth factors, about 60 different types, that stimulate blood flow into the area, that stimulate collagen formation, and that stimulate the healing event that we're looking for. And over the next several days to weeks, healing occurs. And then remodeling occurs over several months. Now, great examples here from my, my charts on some of the patients to show you the potential that's so exciting about biologic procedures. 51-year-old female, 2 years of chronic knee pain. She's had 2 medial meniscectomies. She's got moderate arthritis. She's tried all these different treatments. Nothing's helped. And we did PRP, platelet-rich plasma, and she was 80% improved at 8 weeks. Or this example, a 16-year-old male tennis athlete, 12 months of persistent shoulder pain, tried PT, did rest, modified his strokes, did anti-inflammatories, but wasn't better. We did a series of 3 growth factors of PRP, and at 6 weeks, 90% better. And now years out, right, he's a nationally ranked athlete and no symptoms in the shoulder. Good news. 45-year-old female avid CrossFitter and runner with more than 3 months of proximal hamstring pain and MRI-proven partial tear. We put some fat in there and injected it in along with PRP. 95% better at 8 weeks. A beautiful outcome, right? Tennis professional with left knee pain and swelling, an MRI-proven notable tear. You can notice kind of here, x-rays look very nice and clean and symmetric. But when you look at the MRI, you can see this white line right here through the meniscus. That's the tear. And here you can even see how the meniscus is pushed out of the joint a bit. And so there's not a lot of cushion remaining there. And had he just had a scope to take the meniscus out, he would have run the risk of 300 to 600% increased risk of arthritis. But instead, right, we're able to put PRP in there. And you can see here is some bone marrow edema, right, from the contact between those bones. And, there he is, a couple months after doing slacklining with no pain in the knee. So very cool stories to hear these outcomes, right? This one was a nice one, a full thickness tear of one of the rotator cuff tendons through 70% of the tendon. And here's the tear right here. This is on ultrasound. This is the tendon coming out. This is the tear area here. And here's my needle going in. And you can see how it's filling that area with fat. Then we put PRP over the top of that. And at 8 weeks, right, he was 90+% all better. Beautiful outcome. Now, the problem is for physicians, of course, there's a desire to help, and then there are lots of competing interests. And I think that's what you're seeing right now in our culture. You're seeing places pop up with very poorly trained clinicians who have no real experience in this area, who are injecting people with who knows what, and are often injecting blindly without ultrasound or x-ray guidance. Why? Because it's cheaper and you don't have to be well educated. And so there's all kinds of confusion about what really works, what should be done. And tonight I want to share with you what the science says about all of this, okay? Because we as clinicians have taken a commitment that says, first, do no harm, and the needs of the patient come first. But unfortunately, many clinicians begin to fall into traps, focused more on financial gain. This is why we see the price points so outrageously high for many of these procedures. So for example, PRP around Jacksonville can be anywhere from $800 to $1,500 for an injection. I'm very proud to say I do it for $400. And yet I use one of the most expensive kits and preparation devices, et cetera. So we want to help people. That should be our goal. That certainly is mine. And that's why I'm with you this evening. Now, orthobiologics, this is the use of a biologic substance to prompt, stimulate, or support a healing event within the body. There are two major types of orthobiologics, right? Those are autografts, meaning from you, or allografts, meaning from another. Right away, when you see this, you get the sense of, okay, these are two big classes, very different. And the risks between these are very different, as we'll talk about. The most elemental type of biologic that is used would be platelets. What are they? We throw the word around all the time, PRP, platelet-rich plasma. So platelets are these fragments of other marrow cells, meaning little cells that live inside your bones. And they're 20% the diameter of a red blood cell. They're tiny, but they're loaded with growth factors. And here on this microscope view, you can appreciate that right in here, these little black pockets are something called alpha granules. And then these alpha granules are different types of growth factors that cause things like protein synthesis, bleeding, stopping it, growing blood vessels, and attracting stem cells. These different growth factors have different names. You can see some of them here, the shortened names and version of them, and they're remarkably powerful. So if you cut yourself, well, these platelets rush to the area through chemical signaling. They release little growth factors that then prompt clotting and then set off a healing cascade. This healing cascade then continues, as we talked about, for weeks to months. So when you look at the blood, right, our blood is 55% plasma, 45% red blood cells, and really less than 1% are platelets and some of the white blood cells. And so when we look at this, right, the platelets are a tiny little amount. So normal blood would be all of this red blood cells and a little bit of plasma here, or forgive me, a little bit of platelets here. Versus when we spin it down and concentrate it, now we get all this nice platelets, right, with a little bit of red blood cells and plasma. So we go from a hematocrit of 50% or so to a hematocrit of 0 to 7%. Very small amount of red blood cells in there. Now, not all kits are created equal. Not all companies are created equal. So if you look at independent papers, there's some PRP, quote unquote, injections that are less than 40% of the platelets that they draw out. They just don't capture all those platelets. Versus other kit companies in independent papers are giving you 85 to 90% of all the platelets that you might have in your bloodstream, and they're concentrating them. Those are the sort of devices and techniques and kits that I use. Next in our definition would be bone marrow. So bone marrow is the fatty connective tissue inside your bones. And when you're young, to be young again, when you're young, it is all red marrow. That means it's extremely active. It's producing all of your blood cells, right? Your red blood cells, white blood cells, platelets, et cetera. Very, very active, right? And when you get older, however, now that marrow, in fact, begins to be more of a repository, more of a storage site, instead of being this just really robust active area. Now, we still maintain some active areas, and those would be in the pelvis, the heels, the ribs, and your skull. And for obvious reasons, the hip, if we're going to harvest bone marrow, is a preferable place. The other areas are either too painful or too risky. The next area of biologics, it would be fat. And it turns out fat is an impressive storehouse of growth factors and of different types of pericytes or stem cells. And so that's a good thing about fat. We talked last week about the bad things about fat, producing adipokines and causing inflammation. But in this case, it's actually quite helpful as a source that we can use to harvest stem cells. Now, stem cells are these undifferentiated little primitive cells in our body. And by definition, to be a stem cell, you have to be capable of renewing yourself. And under certain conditions, you have to be able to induce into, right, or become a specific tissue or organ-specific cell. So very, very interesting, these little cells, and extraordinarily important in our bodies. Now, there are multiple types of stem cells. We've got the totipotent, This would be from the early stages of the embryo, meaning these can just kind of rapidly turn into just about anything. Then we've got pluripotent, which are from, again, still the amniotic phase. And then we've got multipotent. These can be from full-term infants, from cord blood, and from adult stem cells. And while these cells can differentiate, they have some limits kind of in what they are capable of doing, which, as we'll talk about, may in fact be a good thing, right? Because as you and I both know, cancer is uncontrolled differentiation and growth of cells in ways that we don't want. And so we don't necessarily want cells that are completely untamed and out of control. Now, in our bodies, right, these mesenchymal cells come in either, as I mentioned, as bone marrow derived or adipose derived. Now, here I am drawing bone marrow out of somebody. When I was in residency, we always thought, oh my goodness, bone marrow aspirations are the most horrible things ever. I've been surprised over the years at how tolerant most people are. I tell people it's about 2 minutes of a weird sucking pain in the back of your hip, but it goes very quickly, and immediately when we're done, the pain usually goes away. Very rare occasion is somebody sore for several days after. But this is where we harvest from what's called the posterior superior iliac spine, and we'll talk about that procedure in more depth later. Adipose tissue, as you might guess, is just liposuction. And so we do a simple liposuction, deriving the fat, and then either breaking it down through chemical measures or breaking it down through mechanical stimulus. The placental-based tissues in America that are allowable to be used are from full-term infants. And so from this sort of amnion, right, this layer around the baby, right, or from the placenta itself. Another area that you may hear thrown around is a term called exosomes. These little tiny fluid-filled areas are present in many eukaryotic cells, or in other words, cells of people or humans and animals, et cetera. And, you know, exosomes contain different types of proteins, yeah? And they appear to have a biological effect on, you know, kind of gene expression and on the cells around them. But exactly what that effect is in the musculoskeletal world has not been fully differentiated. It does appear that there may be some benefit, but as we'll talk about, there are not a lot of studies kind of for its use in the musculoskeletal world. The basic area of allografts would be prolotherapy. Prolotherapy is a style of injection or a type of injection championed by Hackett and Hemwall, two physicians of the University of Wisconsin. And this is the use of a noxious agent like a dextrose, a sugar water, or vitamin C, injected around ligaments and sometimes into joints in order to create sort of an inflammatory, short-term inflammatory response that then causes the ligaments to snug up, tighten, and to now stabilize the joint and improve the health of the area. Now, with any of these injections, the risks are quite similar, right? There's some variety, but we'll talk about those. And those risks include infection, bleeding, nerve injury. It doesn't work, right? Et cetera. So these need to be always weighed with regards to the type of injection and the condition the individual has, right? Is it worth this risk, right? Is the pain that you're having really worth the risk? These are real because when you look, if you just Google search online, you're going to see multiple cases of issues with stem cells. Now, in fairness, the majority of these are in individuals who received allograft injections, meaning placental amniotic-based solutions, without clear understanding of how it was processed, whether it was pure, whether it had HIV in it, whether it had bacterial infections. These are all real problems with allografts. And many of these people had pretty significant problems ending up in the ER, et cetera. Or US Stem Cells in Miami, which was a large organization, was injecting stem cells into people's eyes, which led to blindness in multiple parties. So again, very important that we are, what did Groucho Marx say? Something to the effect of we open up our mind, but not so far that our brain falls out, right? So we want to be open to doing things in the biologic world, but we need to stay within the realms of science, not necessarily of anecdote, hope, or ideas, because there are real risks related to these procedures, especially if done by somebody who doesn't know what they're doing. I'm very proud to report that in having thousands of these injections that I've done, I've never had a single infection. And I want to keep it that way because I'm very proud of that number, that zero number in this case. And I think it's a combination of perhaps good luck and goodwill from above, as well as excellent technique, right? And hygiene and antiseptic technique with every patient. And also the fact that when we put a biologic substance into a joint, it inhibits bacteria immediately. So again, good outcomes, but you want to make sure that the people who are doing your injections, wherever you are really on top of their A game with their, care and their care of you to reduce that risk as much as possible. So now, why go get biologic injections anyway, right? Well, they'd be usually for pain, function, or prevention. So osteoarthritis, tendon injuries, and other soft tissue injuries. These would be reasons to be seen for this condition. And this is where we need to get down to the brass tacks on this, right? Is there a need? And if there's a need, well, is there a science-based mechanism? And if there's a science-based mechanism, well, do we have any studies in animals and studies in humans that show it works? So, we know that we humans, especially here in the Western world in the US, are aging rapidly. The baby boomers are booming, as they say. And so some of the most rapidly growing percentage of the population are those in the ages of 65 and above. And with that increase in age, of course, come reported limitations from musculoskeletal conditions. So we have an aging population, we have musculoskeletal issues, and as we talked about previously, we have a rapidly increasing amount of obesity as well. And so this combination of increased weight, increased inflammation, increased age are this perfect storm, right? Leading to degenerative joint disease and injury. And so there is definitely a need for this. Now, what about a mechanism of action? Let's start with PRP. We want to be able to postulate, right? So if somebody says to me, hey, do you know that eating more vegetables is good for your health? I'm going to ask the question, well, based on what science? How would it help me? And you might say, well, it has water and it has fiber and the roughage and the micronutrients. And when you eat lots of it, you can't eat other junk food because you're so full, right? So lots of different reasons, right? It helps decrease my cholesterol, blah, blah, blah. Well, the same thing we should ask when it comes to biologics. Don't just accept someone's word like, ooh, this is great. It's going to help you so much. It's like, oh, enough with the voodoo. Let's actually give me some science. So here are the mechanisms of action of PRP. Number one, as I mentioned, they deliver growth factors. Number two, when you put PRP into a specific area, it increases the body's production of growth factors for multiple weeks after. Number three, when you put PRP into a joint, it stimulates the joint to produce more hyaluronic acid, more of the gel, the lubricant in the joint itself. So that's a good thing. Number four, when you put a lot of platelets together in one area, they attract stem cells. So as a result, we get these stem cells coming to an area where lots of platelets are hanging out all together. These are four well-proven, scientifically based manners in which PRP, for example, can be helpful. Now let's get into the clinical studies. We're going to jump through these. You can come back and review them later if you want. We're going to point out the limitations, and we're going to point out the good quality ones as well. We're going to talk about why, right, different areas don't seem to do as well, et cetera. So PRP for chronic Achilles tendinosis, yeah? Early study showed that if you took people and they got PRP and they knew what they were getting and they were tracked out multiple months, that 28 out of 30, so small group, had clinical success, meaning all their pain went away. MRI showed 27 of 29, the tendinopathy went away. Now, I do want to point out to you though, right? Again, these are people who had continued follow-up over time and likely took time from it. It was not one of those like, well, I did it and now I feel better. But rather, it took several weeks to months for resolution. PRP injections of chronic plantar fasciitis, right? Same sort of thing here. We see that in people who receive it, right? Excellent in 60% of people, good in 14%, acceptable in 2%, right? But about 7% of people saying poor. Multiple studies that show that PRP is better than steroids for chronic plantar fasciitis. Longer term results, less reinjection and or surgery rate in people who receive the PRP. And so, there is data. There are multiple other studies out there that you can look at. Some of them are on my website. If you go to the PRP tab and then go PRP science, you'll see a bunch of these studies there. Now, another area of soft tissue issue, which is very common, is the lateral epicondylosis or tennis elbow, pain on the outside of the elbow. And, initially, you can see this here, right? So in people who got steroid versus PRP at a 2-year follow-up, right? 70% or so of people with PRP were better. Only 15% of those with steroid were still better. So the PRP having a good long-term benefit. But part of the challenge in these studies, I'm going to bring this up for you, the science-wise, so you can nerd out on it like I do, is that when you do a PRP injection, you're also introducing a needle into the tendon. And so how much of the benefit is the PRP? How much is just purely what we call a tenotomy, that you're making little holes in the tendon and that stimulates growth factor release and stem cell activation. And so here they did this. And again, the PRP did better, but not radically better, 83 versus 68% of benefit. Then here, if you looked at people who were recalcitrant, meaning no matter what they did, they weren't getting better, and they either went to PRP or surgery, pain relief was about the same. Very interesting, but it's long-term follow-up. Now I want to show you a couple studies, though, that did not show massive differences, right? These are people who got saltwater injections or steroid or PRP, and there was no difference. Very interesting. Why would that be? And then there are more studies like this where you can see that the PRP doing better, again, than steroid in the tennis elbow. And another study here showing that, PRP, right, may or may not. And this one, a meta-analysis in 2018 saying no strong evidence does not support the use of PRP or other treatments. But then right behind it, right, came another study, right, very close nearby, and saying, hey, when we look at 5 trials and compare them all, actually PRP is better. In fact, 70% of patients treated with PRP avoiding surgical intervention, right? And then again, more meta-analyses in the last couple of years showing benefits, right? PRP appearing to be a benefit. Now, as a clinician, some of that data is hard to wrap my brain around because studies say that it does, studies say that it doesn't. Well, which one is it? And the challenge is that each of those studies use different concentrations of platelets. They use different equipment, some with and without guidance appropriately, some with, injecting anesthetics into the tendon that washed out the platelets, some doing just one injection over the top of the tendon, others doing a tenotomy. So the problem that we face is the variety, right? All these variables, many of which were different. And that's a problem with some of the research on soft tissue use of PRP. When we look at, let's say, retrospective analysis, this was an early study done by Ken Mountainer at Emory, and he looked at his cases of his patients, 180 of them that he had treated, and he followed their outcomes. Well, 82% reported moderate to complete improvement of their soft tissue tendinopathy. Pretty good, right? An 80% plus success rate. And 85% reported satisfaction, right? They were like, well, I'm better than I was, even if I'm not 100%. So, this is worthwhile looking at. So if you know what you're getting, 85%, and somebody does it who knows what the heck they're doing and puts it in the right places, in his data, 85% reported the benefit they want. So, interesting. But again, pure science, there is a lot of variability. Now, that's different than when we come to PRP and osteoarthritis. If we look at the data, early studies showing that PRP was safe, that people improved as far as pain and function, their quality of life with long-term follow-ups. And that has continued over time, continuing to show us that PRP is comparable as far as safety to just salt water, but much better improvements with regards to pain, with regards to walking scores, with regards to function, et cetera. Better than prolotherapy, better than gel injections, right? So when we look at this, right, we want to make sure that we understand this, right? So that PRP is better than hyaluronic acid and better than corticosteroid injections for individuals with mild to moderate knee osteoarthritis. So if you've got knee pain, you should not be thinking about getting, gel or steroid and then waiting till it stops working and then going to a PRP. If the cost is what's holding you back, come see me, right? But it's much better to put PRP in there when your knee is healthy rather than burning it out with steroid until there's just trashed and there's nothing left, and then hoping that some PRP will give you a miracle. Because again, meta-analysis, again and again, showing us that PRP with 30 plus, 40 plus studies reviewed, very, very effective when it comes to these issues. And really fascinating, some new data in the last 2 years showing us that if you compare people to saltwater, steroid, or PRP and follow their arthritis in the knees, PRP has the least progression. This means that as you and I age, it may in fact be the right choice for us to begin to get PRP as a preventive strategy. We get that mild, bordering on moderate OA, maybe it's time to get the PRP, even if our symptoms are minimal, because we don't want it to progress. So over 14,000 articles, more than that now, published, and showing good benefit. Now, in severe to end stage OA, the benefit is less robust. Doesn't mean we don't do it. It just means they may not get the long-term benefit we'd like. When it comes to soft tissue issues, Well, ligaments mixed results, meniscus depends on the size. Like today, I saw somebody in clinic. I did it for their meniscus. They're like, yeah, I'm 85, 90% better, able to do most of all the things I love and enjoy with no pain. That makes me happy. That's what we're looking for individuals. Now, what about stem cells? So stem cells, right? First of all, we want to know about the safety. Now, safety with stem cells varies really dependent upon whether we're talking about, autologous or allografts. When it comes to autologous, long-term follow-up studies show no, right? No cancer, no infections. In other words, if we take your stem cells out of your bone marrow, concentrate them and inject them in your joints, we're not going to be inducing some little hairy, cancer inside of you. Now, if you take it from a, unborn child, from the amniotic fluids, things like that, we don't have that data long-term to kind of understand the implications long-term. Now, the initial studies that got me doing bone marrow-derived stem cell were some of these. They were in animals. I apologize, the animal. But what they did was induce arthritis in the joint, then harvest the animal they would induce arthritis in the joint, then they would fluorescently tag stem cells derived from the bone marrow, and then inject them into the joint. And they would track where these fluorescently tagged stem cells went. And they could see that these stem cells went into collagen layers and incorporated themselves in the areas of injury. Quite fascinating. And so it was these studies in animals, right, where there's no placebo effect, that prompted me to say, okay, I want to start doing this for my patients. Now, follow-up data, right, kind of in humans, initially looking at, for example, this study with osteoarthritis and rotator cuff tears, and then long-lasting benefits as compared to total knee replacements. And then, list goes on and on with regards to arthritis. Now, I want to bring up this case real quick because it's important to understand stem cells are not a panacea. And I hate to see these ads on TV and the radio that promise you, like, essentially, that your knee will be like a 12-year-old again. And then they rip people off for $10,000, which I, by the way, charge around $2,800 for doing bone marrow-derived stem cell. And for that reason, I have people fly in from out of state, et cetera, and drive multiple miles so that we can do this and save them money. And, this is a great example, though, of it not being a panacea. This is a 77-year-old female presented with see me, who initially on old x-rays had moderate knee OA. And if you look on these x-rays, they were minimal arthritis. But on her MRI, she had a meniscus tear, and then she had this little cystic change. Now, the surgeon, he said, well, let me scope your knee and take that meniscus out. Ay, horrible choice, right? And look at what happened. Within less than 1 year, we were at this, right? Right around 1 year, she's now bone on bone. So we went from this here to this here. Why? Because he scoped her knee. And this, unfortunately, is what some sort of unethical, I'm not saying all are, some unethical orthopedic surgeons do. They will say, oh, you got a meniscus tear, let me scope it. And then they scope it when they know they shouldn't, because the person already has arthritis, which you can see here on this MRI, for example, this cystic change. And then when the person doesn't get any better and they're living off steroid injections and they have advanced OA, they say, oh, well, we tried to do our best. But, things just kind of progress. Now let's replace your knee. Well, the answer would have been to do a biologic at this time, right? A PRP or a stem cell, not to do surgery. So when I did her procedure, I told her, look, I don't think it's going to help you, right? You're bone on bone. You've already had these surgeries. You've done tons of steroid injections. We did it because she wanted to do it. And sure enough, she got no better and she moved on and had her knee replaced. And that was appropriate. Now, next, again, more studies here are just showing you meta-analysis, kind of showing significant functional improvement and pain relief for folks, right? Again, even in people with rheumatoid arthritis who receive a bone marrow-derived stem cell, showing benefits, right? A nice triple-blind placebo-controlled, trial. Follow-up studies showing that they're safe, effective, and have benefits. So again, all of these studies showing nice promise, right, for individuals, a slowing of the progression of arthritis, an improvement in their pain and function, Sampson et al. Did a nice study in 2016 out of UCLA, showing 125 people and showing that one injection of bone marrow-derived stem cell and one injection of PRP at 8 weeks later, you can see here by 6 months, 70% reduction in joint pain, 91% said they would repeat the procedure. That's a pretty good outcome. Keeping in mind, right, this isn't people even with moderate to advanced osteoarthritis. And I will say, I see very similar results, right, in my individuals. We call this the UCLA protocol. Bone marrow, and then 6 weeks or so afterwards, doing a PRP to try to stimulate the area and feed those stem cells. So an improvement in pain, an improvement in function, these are all very promising. When it comes to fats, there are two versions of fat out there. One is a stromal vascular fraction, where there's a chemical used to break down the fat and release in the stem cells. And the second one is a microfragmenting, a breakdown of them using mechanical stimulation. And so if you look again, very nice and very promising benefit. And each year there are more and more of these studies showing good outcomes. I tend to use the mechanical stimulus device, which is called lipogems. And in their studies, at up to 2-year follow-ups, 88% of people show great benefits, significant improvements in quality of life, function, and a reduction in pain. So quite good. And that's even in individuals of grade 3 and grade 4, which is relatively advanced osteoarthritis in the knee. So I would argue that my outcomes are about the same. About 12 to 15% of people fail, and about 80 plus 88% of people do well and have a good outcome and are like, wow, I am way better than I was. And that benefit, in my experience, can last anywhere from 3 to 10 years. And that's the sort of benefit that we'd like to see in patients, right? So it kind of improves their quality of life and function, reduces pain, and keeps them away from the knife, which is good. Because remember, knee replacements are not a panacea. Only about 70% of people are happy afterwards, and they only last 15 to 20 years. So if you do it when you're young, you have to repeat this noxious procedure. Not to mention the risk of mortality within 90 days is quite high, et cetera. So we'd like to avoid those if possible, as long as possible. Again, another study here you can see the microfragmented fat at 2-year follow-ups. Amniotic-based solutions have very few studies. Very important you're aware of this. So although there's a great amount of hype with regards to the potential of amniotic-based solutions, there are not a lot of studies, and those that are out there are in small numbers of individuals. Some of them, quite a few of them are in animals, as you can see here, one on Lewis rats. And those that are present do show some improvement in both pain, function, et cetera, but it is not magical. So in other words, for those of you who are nervous, as you should be, about receiving a biologic, quote, stem cell injection at a chiropractor's office with a random mid-level provider injecting you blindly with something out of a vial, that's not going to be magic for you. You don't have to go that route. You can go the real route of your own cells and using them to try to stimulate a healing event and reducing your pain and improve your quality of life. And so, as we develop and see more studies using amniotic solutions, well, then I'm more than happy to become more of an adopter. So I have done quite a few of these for people who have brought me amniotic solutions. They've had the rep come in from a big company, and they've paid the company directly, and I've done the injections for free. And the overwhelming majority that I've done have not produced significant benefit. So that's very important to kind of be aware of. Again, as the data improves over time, I might change my mind because I'm a scientist, right? So as the science grows and progresses, I should be open to that modification, in my opinion. So in development, other areas like cord blood, peripherally harvested stem cells, and the like, but we're not there yet. So people sometimes come see me and say, hey, my great-grandchild has like cord blood, can I use it? We have no way to use that. We have no knowledge that it's going to give you any significant benefit. So I recommend not using that cord blood for those purposes. So, the potential is extremely real. The lab data and animal data is exciting. Clinical application varies depending upon the studies, how we're doing them, et cetera. The anecdotes are remarkable, but it's important to keep in mind this is not a panacea. And as a result, when I say this, I say it because thus we should have fair pricing. We should not be price gouging people just because we can, right? So the average price point, I think, for lipogems around the US is anywhere from $6,000 to $10,000. I do it for $2,800. My goal is to help more people. That's why I'm with you this evening sharing this message so that you can learn more about stem cells and about PRP in a science-based way, not in a way that somebody's just trying to get you to buy their product. Let's talk briefly about the procedures. PRP is straightforward. You draw the blood, you spin it multiple times, you hyperconcentrate the growth factors, and you inject them into the body in an area of injury. Now, stem cell derived from bone marrow, we numb the back of the hip. This is the back of the pelvis. We then make a tiny little blade incision. We then put a trocar in, and we push that into the bone. And then we draw out the bone marrow. You can see it there. And then we spin this down and hyperconcentrate the stem cells by about 33 times, whatever we draw. This is what is left right here. And so minimally invasive, we get some beautiful cells to use. Bone, the other is the fat, of course, and this is, as I mentioned, truly a liposuction. So what I do is I inject along the surface of the skin. I inject a little deeper, wait 15 minutes, draw out the fat, then using a device, shake and microfragment, breaking up the fat, washing it. Then we take that product and we inject it under ultrasound guidance into the joints. I just did some of those today for individuals. And the injections should always be done with great sterile technique, and they should always be done under ultrasound or X-ray guidance, so you know where you are putting this solution. Now, there are a lot of contraindications to these procedures, and they include people who have used anti-inflammatories, had steroid injections, people who are on blood thinners, people with active cancer. These are all very, very important contraindications, or people who have, very low platelet counts, et cetera. So it's fascinating to me because I can tell who knows what they're doing as far as physicians if they're following these recommendations. Because I will sometimes hear from patients, oh, wow, yeah, I went and had my steroid injection and that wasn't getting me by. And so one day, so 2 weeks later, I went and had stem cells. Well, that makes no sense, right? Or the person who gets a PRP injection while they're still on their blood thinner, or they're still on anti-inflammatories. Remember, these medications inhibit platelet function. So if your provider does not take you off these medications, you should run away because they clearly have no idea what they're doing. Same sort of contraindications for bone marrow or for fat. So this is an extremely exciting area of medicine. There is immense potential, and the benefits can last for years and years. And so, the reality is your own cells have a lower risk. Unmanipulated, they have lower risk. Localized injections guided by either ultrasound or CT, and a physician who knows what they're doing. These are the people who should be doing these procedures for you and in this fashion. If you are going to a chiropractor's office, the chiropractor is not even allowed to inject you, right, by law, and they are having a random mid-level inject you, and that mid-level is being supervised by some random physician you never even meet, I think you get the idea that this is not an appropriate way to do it. And what this is about is money. And the charge, right, is going to have to be split to 3 different people, the medical doctor, the PA, and the chiropractor. So as a result, they're going to have to charge you more than is fair and equitable. So don't, don't settle for halfway. Get the highest quality wherever you are. All injections should be done in the most sterile technique. They should be done with your cells and your materials, and they should be injected under ultrasound or X-ray guidance by someone who knows what they're doing. And has been doing a lot of them, right? This is very, very important stuff. So with that, I'm going to look to see if there are any questions from all of you. If I can be of service to you, please go to my website at essersports.com. And there's a bunch of additional science there. On each page, whether it be bone marrow, PRP, or fat-derived stem cell, you can click on the science link at the bottom of the page, and it'll take you to a page of a bunch of different scientific articles and the links to those, and you can read them in detail. So if you have specific questions about stem cell and whether you're a candidate, or PRP and whether you're a candidate, please go onto the website. There is a contact us link that you can use there. The reality is, I love doing these procedures because when they help people, which 80 to 85% of the time, if not more, they do, it is just delightful because we're using your own materials in a way that therapeutically affects your quality of life. And there's nothing better than seeing people get back to what they love and enjoy, which is cool stuff. So essersports.com, and I do both teleconsults and an in-person exam if you are interested. Let's take a look here and see what people are saying. I see some hellos. Well, hello to you as well. And thanks for joining, and thanks for learning with me. So I'm glad that you all joined and came to hang out. And that's about it. Please share with your friends and family, especially anybody who's considering doing PRP or stem cell. Make sure that they're well educated. They make informed decisions about the amazing potential, but also the limitations of these exciting procedures. And if I can be of service to you, if you're outside of Florida, on my website, you can book what's called a biocon, which is a bioconversation, a conversation about biologics. And if you're in Florida, I can do a true medical visit with you and talk about your candidacy, or either teleconsult or in person. Because I have some people, they just reach out to me and they just want to get my opinion because they're considering doing something and they just want to make sure they're going to the right place. So it's always a pleasure to help. I hope you all have a wonderful daytime or evening whenever you're watching this. And again, if I can be of service to you, EzraSports.com. All right, everybody, have a great evening and thanks for joining.